As many of you know, Dr. Nawaz has been trialing out the FMA for quite some time now, or on and off. So, can you give us a little update on your FMA and
Yeah,
progress?
absolutely. The FMA has a few different components. There is the protraction wire, that wire apparatus, of course, which you can show in a picture-in-picture. That wire apparatus hooks onto the back of the FME device and has a little bar that contains an attachment to then hook up the body gear that you then use a force applicator as the conduit between the FMA wire and the face mask to pull, right? And for a long time, I had one component in one place and another component in another place and this and that. And I finally got around to trying it. So the initial trial of the appliance basically suggests that this is a very robust device. You can certainly feel traction in the midface. The device definitely works. It's very well thought out of, or very well thought out in terms of, having these individual components that are very intentional about the vector of pulling. And also, this is the world's first case of a protraction apparatus being custom fit to a patient. And what I mean by that is that the protraction wire, of course, goes around an individual's own, arch and hooks into their FME. And then the planning of where that little hook point is for the pulling is all CBCT guided. And also ensuring that when we are pulling, just because there's not really any forgiveness in the device in terms of being able to, you can't just necessarily pull it one way or another way. It pulls only one way. So that all has to be determined on the CBCT, whether it is facially appropriate and, of course, in a purely forward direction.
So, for each FMA, it's customized for the dentition and also for the vector that we want for the maxilla to move. And so, Dr. Newaz and myself, we go through these, we approve them before they're made as well.
And so as far as it looking like it's a reliable device to use, absolutely, right? Now, as far as my own individual journey of actually protracting the maxilla, right? I'm more using this at this point as just a method to demonstrate that facial protraction is possible and feasible. I don't know if I still have my, main window for protraction. And what I mean by that is I've, of course, been expanding slowly since September 29th of last year, right? I've now had this device in a little over 10 months. And, of course, the first X number of months, let's just call it 6, I was, turning somewhat consistently. These days, I'll, see the wrench, a couple times a month and maybe give it a crank or something. But that's about what my relationship is with the FME now. I'm just pretty much holding, and I'm being somewhat lazy about starting the orthodontics. And essentially, right now, there's still a little bit of runway that I have with either using the few turns that might be left in my existing module, 9mm expansion cube. I can either put the 11mm cube in there or what's called the B series, which has also been, made, and that will give up to 15mm. I don't think I need to expand up to 15mm, but certainly to be able to get another couple millimeters out of this, I would, I think that would be what it would take to re-loosen the sutures to make them receptive to any sort of attempt to actually protract. But I'm guarded in my optimism of actually getting protraction because I'm 38 years old and I've already mostly consolidated with my expansion. So I think it's important for the community to know. A lot of people I know are curious about, oh my gosh, how's this protraction going? I'm mostly at this point testing to make sure that protraction is feasible and safe with this device and help advise the company on some of the practicalities of this whole system that has
Like how it sets up, how it fits on the body,
Correct.
how it affects the teeth, things like that.
Exactly. And then the other hurdle in my particular case was that, of course, the protraction wire was made according to the virtual placement of the device initially. And then you expand a certain amount. Of course, how your maxilla then responds and expands may affect what basically the protraction wire, which is, it has a little expansion screw within it so that as you're expanding, you can protract using the protraction wire that has the same amount of expansion as your expander, right? So when I made the number of turns to make my wire match my expander, the expander wire is kind of binding on the edges of my teeth a little bit. All that really means is that there just needs to be a little bit more clearance on the outside of the wire, meaning these are, and that's, again, I was a very good first case to kind of show the company that, hey, when we make these wires, we might want to just give a little bit more clearance away from the teeth to ensure that, the teeth aren't going to have, really, like, they're not going to provide interference with where the wire can sit. If you can imagine the wire hooking onto the back and looping around the molars without touching them, well, if it is touching it, then it might not be able to situate at the vector of intended protraction. So mine, it situates, but it has to angle down a little bit, and it's not the intended vector of pulling when I have mine in and it's secure and it's, available for pulling. We have to almost pull it down so that it's not interfering with my teeth a little bit, right? So again, the way around that, now that we've identified as what will probably become protocol for users of the FMA, of course, some people will be in the future getting their FMAs pretty much along with their FME. For such people, it's, you basically have the same starting records for fabrication of the FME and the FMA wire, right? And then either going to be other people who have started their FME and they've maybe gotten some expansion. Well, then now best practice is to scan the maxilla with the, with the FME in place and take a CBCT scan. And then those are then used to then, contemplate the fabrication of the wire to where the patient is at that time so that we don't have to, retroactively basically make the FMA wire and then, prospectively turn that same wire to where the patient presumably is with their expansion. I think that it has to basically be fit from the time that you intend to use it.
Are you going to be getting a new wire?
I'm going to get a new wire because, again, I'm still hopeful for actually getting some protraction, even if it's a little bit. Again, by hopeful, I don't mean that, by hopeful, I'm not talking necessarily about the expectation. I think my expectation is near zero to actually get protraction. But I'm hopeful in the sense that I think it's worth trying, right? Even if it's for little to no return. Of course, the best case scenario in a situation like that is that I'm wrong, right? And so I would love to be wrong about, perhaps not being able to get protraction at my age. And I think if the right, of course, the well-fitting wire plus, maybe high force application plus me being
Consistency.
Travel with. Yeah.
So, in all honesty, you do have a pretty strenuous lifestyle and work schedule. And the practicality sometimes.
Practicality is definitely
versus
an issue.
If somebody does have a consistent bed they sleep on 7 nights a week, it may be a little bit easier to use your protraction device.
Exactly. I think I have some of these logistical hurdles, but I think if I can.
But I think the priority with where your role is, does it fit?
Yeah.
Does it, go around the teeth? How are the forces feeling to your maxilla?
Yeah.
How does it fit on your chest? Can you work with it and the computer, or can you lie down with it? It's more like practicality of the execution of it. versus am I actually going to get protraction out of it at this point?
Exactly.
If you do get protraction, what could this mean for, approach treatment cases in adults?
Well, we have gotten protraction on adults. Now, it's a we say very guarded, right? Because it's hard to measure. It's hard to say, if you put 2 kilograms of force, it's going to yield X amount of millimeters of protraction. But so far, we have had cases where patients in their mid to upper 30s have moved forward.
Well, and what it could mean is actually a somewhat profound question, because what it could mean is that as we refine the predictability, case selection, and efficacy of midfacial protraction in adults, which is not a topic that has been studied in any capacity for a non-syndromic patient, right? If we can demonstrate that that is something, whether it comes through FMA or some other mechanism, but if midfacial adult protraction is a thing, right? And let's just call FMA our main, most robust, most reproducible system to achieve that. If that is a thing, then that could really alter decision-making in structural modification or orthodontics. That's why I said it's a profound thing. Because yes, we do have patients who have gotten some results, but they've been, more exceptional cases, right? The ones that can wear their, thing all the time, and because, and they can afford to have that many non-social hours pulling on these, ridiculous contraptions with rubber bands and this and that. And again, we've all seen, anecdotally, I think any of us major expansion providers can point to some cases in our practice that can say, hey, this is an adult who achieved midfacial protraction, at least in some capacity, that was clinically significant for my ability to correct this malocclusion or this upper airway resistance problem. Great, right? But if this becomes actually predictable and it becomes something that can be prescribed in lieu of surgery or in lieu of getting really lucky with forward movement, with expansion, right? All of that kind of stuff. If this becomes, an actual thing, then, we will have more options to offer our patients in terms of, because if you can essentially address the maxilla and the midface, right? Right now, of course, bone-anchored maxillary expansion is the only way to get upper midfacial expansion above the Lefort line, right? Zygoma and, superior third of the nose. Those structures will simply, not expand if using surgical expansion or other, sort of hybrid, kind of SARPy style expansions, right? But if you can couple that with also pulling that whole complex forward, getting suborbital movement, right? Then that is basically mimicking Lefort 2 and maybe even Lefort 3 style movement in some individuals. And obviously that would, the clinical significance of that would be, I think huge. And basically the therapeutic applications, case selection and all that, again, we're looking at basically redefining decision-making in orthodontics. So basically, but the reason why we might want to expand the midface prior to jaw surgery is that you get a unique type of midfacial expansion above the Lefort line. Sometimes that could have a clinical significance, but
with nasal breathing.
With nasal breathing, especially in the superior third of the nose and really opening up, right? If you can get the zygomas to come out too, of course, there's that whole, of course, this is the whole framework for the upper airway, but more specifically, less talked about possible utility of that I'm studying in our patients that are going through this, is that if you can include the zygomatic arch with your expansion, that zygomatic arch being the origins of the master muscle complex, right? If we can bump that out, then we are, influencing the way that muscle sling sits in the face, spatial. So if we can get that, to sit spatially in a way that promotes stretching, promotes lengthening, this is a direct, treatment to overcontracture of muscle responsible for a lot of vertical dimension problems and master muscle hypertonicity problems and other things that are responsible for or concurrent with
Yeah, do you also feel that maybe when you expand the fascia and the skin gets a little tighter, kind of like an intake breathing type of?
Yeah, we definitely see that, where basically if the soft tissue of the face is draping over the scaffolding, over that, the scaffolding that is the midfacial bone structure, and we're pushing that out, we're making, what drapes over it to be a little more.
So like if you go like that, you breathe better. Same thing, similar to the intake.
A similar
Yeah.
type of effect.